This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. It's copyright 2022 and all rights are reserved. Hi, I'm Rich Branson. I'm a professor in the College of Medicine and the Department of Surgery at the University of Cincinnati. I'm also the editor-in-chief of Respiratory Care. Welcome to today's program, High-Frequency Percussive Ventilation in Viral Bronchiolitis.
The webcast is sponsored by an unrestricted educational grant from Syntec.
Upon completion of this AARC webcast, participants will be able to meet the following objectives. Identify the research question of the study, identify the study design, discuss the main results of the study, and discuss the implication of the study on patient care. I'm pleased to introduce Andy Miller. Andy is a pediatric ECMO specialist and pediatric respiratory care practitioner at Duke University Medical Center. He's also the section editor for Pediatrics for Respiratory Care, and quite frankly is our social media chair. Even if he doesn't have the title, he's been instrumental in what the journal does online. And he's the chair of Duke Respiratory Care Services Research Committee. Andy, thanks for joining us.
Thanks for the introduction, Rich. So we're going to start off with a little bit of background on kind of general bronchiolitis. So as most pediatric people know, but maybe the adult people aren't aware, is bronchiolitis it's a common reason. It's not the most common reason for PICU admission, but it's one of the most common. And during viral season, it's the most common. And these patients often require respiratory support. So most of the patients can be kind of bridged through with some nasal suctioning, high flow nasal cannula, maybe some CPAP, maybe some non-invasive ventilation. But about 5%, so that's about 1 in 20 of the kids end up requiring invasive ventilation. And they're difficult to manage. So if you work in a PICU, this is a very challenging patient population because they have sudden changes in pulmonary mechanics. So you have a patient who's doing completely fine, and suddenly they'll have a significant increase in airway resistance and a decrease in tidal volume, which often results in hypoxemia, which can trigger one of the crazy Brady DSATs. They need to be rescued with bagging. And then they have a lot of secretions, which makes it another challenge because the patients often need to be paralyzed, which creates problems with secretion clearance. And then most of the patients can be bridged through just with conventional mechanical ventilation. But there are some that require high frequency ventilation. And so there's lots of different case series out there, control trials comparing which strategy is best. But there's some places that use high frequency jet ventilation. So that's kind of our go-to at Duke. There's some places that use the oscillator. And then there's some places that use high frequency percussive ventilation, which is what this paper is about. And just a little bit of background on why high frequency percussive ventilation is used in bronchiolitis. So the main reason is going to be rescue. So this means that you kind of have refractory gas exchange. So your CO2 is higher than you're okay with. Your pH is lower than you're comfortable with. So that would be ventilation failure. And then sometimes it's oxygenation failure. So you have a high OI, low PF ratio, high FiO2 requirement, despite, kind of reasonably high settings on the conventional ventilator. And then there's some places that use percussive ventilation for secretion clearance. Most of the data for secretion clearance comes from burn patient populations. So there's a couple randomized controlled trials that kind of show conflicting results. They don't show a huge benefit to high frequency percussive ventilation, but there's some very strong people out there that feel that high frequency percussive ventilation improves secretion clearance. And then importantly, which is why this particular paper is important, is there's kind of a limited amount of published data on high frequency percussive ventilation, specifically in bronchiolitis and in children in general, to be honest. There isn't a ton of data on this in kids. And so before we talk about the paper, I want to talk a little bit about how high frequency percussive ventilation works, because it's complicated and it's nuanced. So it's a challenging thing to cover in just a few slides, but I'm going to do my best. So it's a pneumatically powered, time cycle, and pressure limited ventilator. And so how it works is it has continuous high frequency percussive breaths that are overlaid upon a conventional breath. So I'll show you some pictures in the next couple slides because that'll make it easier to understand. But basically, you have a high frequency percussive breath around 200 to 600 a minute. It kind of depends on why you're using it or what your goals are or how big the patient is. And then the conventional breaths are usually in a 1-to-1 I-to-E ratio, but you can use it in different I-to-E ratios if you want. And then the number of conventional breaths vary based on the patient size. And then these last two bullets are really important because how we set the PIP and the PEEP, or the P high and the P low, depending on the terminology at your center, they're actually set by looking at the manometer or the analyzer. So the digital display on top of the machine actually displays the mean value for PIP and PEEP, and not necessarily the actual PEEP or the actual high pressure. And that is important when we talk about the paper. And I'm going to move on and show you, this is a nice graphic from a review article we wrote last year. And you can see here, this is would be P low or PEEP. And you can see that it actually the pressure actually varies around the mean. So for this particular patient, you would say that the PEEP is 10, but even though it goes up and down and it actually varies a little bit. And then you would say that the PIP or the P high would be around 20, but you can see that the actual spikes are a little bit higher than that. And this is pretty pronounced if you ever put an external manometer in line with the VDR. And then this picture is the phasotron, which is what creates these percussive breaths. And it's really important that there's actually two different setups for where you can put the phasotron. So the company recommends that you put it up here by the airway, but there are also centers that use a different circuit setup that's called the turbo hub, which actually moves the phasotron before the heated wire circuit, which is potentially advantageous because there's more pressure attenuation through the circuit. And it also, at least theoretically, is going to provide a little bit better humidity if you do it that way. And they didn't report specifically in this study what they did, but I believe that they used the turbo hub setup at Primary Children's. And then an important thing to discuss when we talk about high frequency percussive ventilation is tidal volume delivery. So we have some bench models that show very high tidal volume delivery. And so when I say very high tidal volume delivery, we're talking somewhere in the 15 to 20 per kilo range with some of the studies. The challenge is that even in a bench model, it's very difficult to measure the tidal volume. So there are some authors that would say that the tidal volume is how much gas goes in and out during each one of these percussive breaths. So you would say each percussive breath's kind of tidal volume is maybe, 50 mLs in an adult. But what really is going to be the tidal volume is all the gas that goes in and out, that goes in and is then exhaled during this entire inspiratory phase. The challenge is that in a bench model, you have to try to measure this, but you actually have gas going in and gas going out at the same time. So it's very difficult to measure that without some really sophisticated equipment. And it's definitely not something that we can measure at the bedside. So that's an important limitation that we'll talk about when we talk about the paper. And then this is just a nice graph to remember that the tidal volume is the difference between how much gas is inhaled during this phase and this phase. And before we get into the paper, I wanted to stress again, so this is a very complicated mode because it's pneumatically powered and it doesn't have any microprocessors. You don't get to just dial in. You don't get to go to the machine and say, I'm going to set the PIP at 24. You have to adjust the knobs very kind of gingerly. They have numbers on them that don't really correlate to anything. So, and then because it's pneumatically powered, every time you adjust one setting, it can, you often have to adjust the other setting. So if you adjust the inspiratory time a little bit, then you have to adjust the expiratory time a little bit. And then you have to turn the PIP up a little bit. Sometimes you have to turn the PEEP up a little bit, et cetera, et cetera. So making what we would normally consider to be a pretty simple adjustment to the ventilator, right? So normally if you want to go down on the inspiratory pressure by 2 during pressure ventilation, you can just go in, you press the dial, the machine does it, you walk away, you go about your day. But unfortunately with the VDR, you have to be very careful, and it's real finicky. And it also sometimes changes the pressure delivery if you change the FiO2 suddenly. So it can be a very challenging mode strategy to work with at the bedside. And because it's so complex, it causes a really high workload for RTs. So there's some centers that actually staff high frequency percussive ventilation one-to-one, where an RT actually stays in the room with the patient all the time, similar to what a lot of centers do for ECMO. And then two other limitations of the mode. You can't monitor the tidal volume, which I already discussed in the previous slide. And then there's a limited alarm package. So it has a high pressure alarm and a low pressure alarm that functions as a disconnect, but going to tell you anything if, especially in a broncholytic, if you have a sudden change in lung mechanics or even a pneumothorax, the machine is not going to let you know that, most likely. Sometimes you can detect these things by looking at some of the waveforms, but the machine is not going to alarm. It's just going to keep running. And so after we've covered the background of kind of how high frequency percussive ventilation works, we'll now get into the paper. So the research question that they were asking was really actually fairly simple. It was to evaluate the use of high frequency percussive ventilation in children with bronchiolitis, which hasn't really been described before, at least in any depth. And they hypothesized that high frequency percussive ventilation would improve both oxygenation and ventilation without compromising hemodynamics, and then without any major complications. And I think this is an interesting hypothesis, because that is what you would observe clinically when you use high frequency percussive ventilation or other high frequency modes. So you often see improved gas exchange. So that's a pretty good hypothesis to test, especially in a smaller study where you're not going to be powered to detect any differences in major patient-oriented outcomes like mortality or length of stay. And then there's no concerns about conflict of interest. So that's really important for studies of unique modes or unique strategies or unique ventilators, because oftentimes researchers have strong relationships with the companies, which despite efforts to be objective, still can either consciously or subconsciously bias the researchers. But we don't have to worry about that with this study. And so how they did the study, this was a single center prospective observational cohort study. So that means that they were observing the patients in real time. So this is a little bit higher quality study design than, say, a retrospective study would be, which is looking through the charts to get some of the data. They did it at only one center, which kind of limits the generalizability a little bit, because we would prefer to have multi-center studies, because then it becomes a little bit more generalizable, because sometimes you get good results like they saw in this study, and that might be related to their experience and expertise, and other centers may not have the same results. So if you have 5 or 6 centers reporting similar results, that makes it kind of more kind of higher level of validity and more likely to be applicable to other centers. And then this was done at Primary Children's in Salt Lake City. They have a lot of experience using high frequency percussive ventilation. And as we already discussed, they included children with a diagnosis of viral bronchiolitis. They excluded babies that were less than 28 days old to exclude perinatal lung disease, and then over 24 months of age, because once you get over 24 months of age, there's a significant overlap with asthma and some other childhood diseases. And then kind of reasonably so, they excluded kids with congenital heart disease, and that because you can't really assess gas exchange in them because of the intracardiac mixing. And then they excluded patients that were only on percussive ventilation for less than 12 hours. And then finally, appropriately so, they excluded kids that went on high frequency percussive ventilation during ECMO, because you can't assess the impact of the ventilator on gas exchange during ECMO. And so how they manage high frequency percussive ventilation. So unfortunately, they didn't protocolize mechanical ventilation. So generally when reading studies like this, it's a little bit stronger design if there's a protocol in place, just because you have some sense that there's a standard way to measure anything, which reduces kind of the amount of confounding in what decisions were made and how it's actually managed at the bedside. They did report that during conventional mechanical ventilation, they targeted a tidal volume of 6 to 8 mLs per kilo, and then they titrated PEEP for what they described as optimal oxygenation and lung recruitment. So I put optimal in quotation marks. They didn't in the paper, because I think there's probably no such thing as an optimal PEEP, and I think that most people would agree, and you can have a whole conference on people arguing on how to set PEEP. Especially even in bronchiolitis, it can be controversial whether we should use higher or lower PEEP. They didn't standardize sedation management or supportive treatments, which means that how they sedated or the use of prone positioning or other airway clearance therapies and all of those things were also not standardized. And then important limitation, as we talked about earlier, is they used the VDR digital manometer to measure the PIP, the mean airway pressure in the PEEP. So that's possible that, this kind of underestimates what the true PIP was. They did report that they had general agreement on how to manage high frequency percussive ventilation, but I wasn't able to access the actual protocol because I couldn't find it in the supplemental files. And then their primary outcome was change in oxygen saturation index. And the reason they chose this outcome instead of oxygenation index is because they didn't do a whole lot of blood gases, which is, fairly common in pediatrics. We don't put arterial lines in nearly as many patients in pediatrics as we do in adults. So that's kind of a reasonable surrogate outcome. Then secondary outcomes would be SpO2, FiO2 ratio, CO2, PICU length of stay, time on the ventilator, new air leak related to high frequency percussive ventilation, the use of neuromuscular blockade, so whether or not they paralyze the patient, vasopressor use, which is always a concern when you're switching to high frequency ventilation, that you'll compromise the hemodynamics, the need for ECMO after being placed on percussive ventilation, and then mortality. And then unfortunately, they didn't do a power analysis. So a power analysis is basically just it's a way to determine that you enrolled enough subjects so that you don't accidentally make a type 1 error, which is where you didn't enroll enough subjects and you conclude that there wasn't a difference, even though there really is. So it's usually done for physiologic studies. That way you can make sure that you enroll enough patients to truly detect a difference in whatever your outcome is. Despite that, they did a pretty good job with their statistical analysis, and then there was no ethical concerns, and they got all the appropriate consents and IRB approvals. And on to the results. So they admitted 192 bronchiolitis patients that required invasive mechanical ventilation, and 21%, which is about 1 in 5, required high frequency percussive ventilation. But then they had to exclude 6, 2 because they improved rapidly and were placed back on conventional mechanical ventilation, and then 3 got worse and were placed on ECMO. And that left a total of 35 subjects. They were a median of 4 months old, 63% were male, and then they were an average of about 6.1 kilos. And importantly, all of the patients in this study met pediatric ARDS criteria. So had mild ARDS, 35% with moderate, and then 39% was severe. And then they were ventilated for a little bit over a day on average before they were placed on percussive ventilation. And so this table just describes the indications for high frequency percussive ventilation. And you can see here, inadequate ventilation was the most common cause. All right, so you have a respiratory acidosis that some of the patients had both oxygenation and ventilation failure. A relatively small percentage were put on for secretion management, and then 11% were put on for just for oxygenation failure. And then the reason that they came off of high frequency percussive ventilation was they got better, about 80%. Other reasons that weren't recorded, which is a little bit surprising in a prospective study that they couldn't figure out what these other reasons were. 6% went on ECMO, and then another 6% failed to have improvement. And so we'll talk about the specific numbers on the next slide, but overall what they found was CO2 decreased, and it's really important to note in this particular study that the reason we say CO2 and not PaCO2 is that they actually combine the arterial and the capillary CO2, which creates a limitation because for those of you that rely on capillary blood gases, they're highly dependent on the perfusion to the foot and how long it took to get the blood and how long it took to get to the lab, and there's lots of confounders as opposed to probably more reliable measurements with the arterial CO2. The oxygen saturation index didn't change. The SpO2, FiO2 did increase, but that's similar to if you put a patient on HFOV, for example, and the OI improved, or the OI didn't change, but the PF ratio improved. That doesn't necessarily indicate that there's actually an improvement in oxygenation. It just shows that the ventilator is doing more work to get you the oxygenation that you need. And then the PIP was lower, the mean airway pressure was higher, and the PEEP was higher. So this could be related to a multitude of things. One is the way we measure PIP during high frequency percussive ventilation, right? So if you put an external manometer in line, the PIP may have actually been higher than it was in conventional ventilation. And then you could also explain that this reduction in CO2 was related to an improvement in lung recruitment because the driving pressure was lower, but that doesn't necessarily fit with the fact that the oxygen saturation index didn't change. So you'd expect with a significant amount of lung recruitment that you would also see a decrease in OSI. And then the difference in PEEP was actually fairly small. And you can see the actual numbers here. So before they went on high frequency percussive ventilation, and then 24 hours later, you can see the PA or the CO2 was 65. You got a fairly decent standard deviation, so a lot of variation here. And then it decreased to 51 with a little bit less variation, which is a statistically significant difference. And you can see here the OSI didn't change. It did decrease, but it wasn't a statistically significant difference. And then there was a statistically significant increase in SpO2 FiO2 ratio from 153 to 210. And then importantly, I highlighted these because the PIP went from around 30 to 25. But if we remember how the VDR works, the true PIP here might have been higher. And then what's really interesting is that the mean airway pressure increased by 2.3, but the PEEP only increased by 0.8, which means that the mean airway pressure somehow increased quite a bit despite a lower driving pressure. So I'm not sure quite how to explain that, other than it could just be the way that the VDR measures mean airway pressure. But not totally explained, because you would expect that with a lower driving pressure and only one of increase in PEEP, that the mean airway pressure would only be about 1 or so higher. More results. So the kids spent a total amount of time on the ventilator, which is a little over a week, which was 9 days, but up to a little bit over 2 weeks at the 75% range here. And then, but their time on high frequency percussive ventilation was about 3.5 days. Most of the kids were between 2.2 and 5.4 days on high frequency percussive ventilation. And then another, limitation or challenge of this study is that nearly all of the patients got neuromuscular blockade or were paralyzed. So I read through this paper a bunch of times, and I could not find exactly what the timing was for when they gave neuromuscular blockade. So for those of you that manage bronchiolitis, even with conventional mechanical ventilation, sometimes you can get a tremendous improvement in gas exchange when you go ahead and paralyze the patients. So it's really important for future studies to report exactly when they got paralyzed. So were they already paralyzed and then they went on high frequency percussive ventilation? My guess is that was the case, but there's no way to know. So it's not entirely clear that this improvement in gas exchange was related to high frequency percussive ventilation. It could have also been related to neuromuscular blockade. And then you can see here the complications were pretty low. Air leak was only 3%. Only 6% of the patients needed vasopressors. Only 6% needed ECMO. And then virtually all of them got antibiotics, or not all, virtually all, but over 90% got antibiotics, which is really related to how sick they are. So if you have a bronchiolitic that's really sick and needs high frequency ventilation, there's a decent chance that they have a iatrogenic infection or bacterial infection on top of their viral illness. So a few discussion points. Excuse me. So ventilation improved, but there was no change in oxygenation. So the authors actually reported that there was a mixed effect on oxygenation because the SpO2 FiO2 ratio improved. But I would say there was no change because I think that the OSI or OI is a better indicator of, sorry, my computer's going a little crazy, is a better indication of oxygenation effect because it includes the cost of the ventilator. So it gives you some sort of sense of how much work the ventilator is doing. They used high frequency percussive ventilation for a wide range of indications. It wasn't just oxygenation failure. It was also ventilation failure and secretion management. And it was a little bit surprising because I've talked to some folks that work there and they said that they use it quite a bit for secretion clearance, but then this study showed it was only 11%. So I think that, you know, sometimes our perceptions of how we practice and what we actually practice are a little bit different, which is why these types of studies are so valuable and important. And then really importantly, they reported minimal complications and that it was quite safe. So that's a very good thing to learn, that despite the machine potentially, you know, delivering or the patients receiving a higher mean airway pressure, it didn't compromise their hemodynamics, and they didn't see a whole lot of barotrauma. So the strengths of the study, so it's prospective data collection. So whenever you're doing a study and you have a choice between retrospective and prospective, prospective is always better because you have a lot more control over what variables you can collect. You can collect more data. And then more importantly, or just as importantly, you can actually ask people at the time of the intervention why they made individual decisions. So why did we go on high frequency percussive ventilation, right? So that's a good question that's often missing from retrospective research because you don't know. And then you can actually, this study is probably too small to really say for sure that that's super duper safe, but you can also, you know, better elucidate the safety outcomes over time. And then you can actually share many more outcomes just because you have you're able to collect more data at the time of the at the time you started high frequency percussive ventilation, and then really importantly, you can actually get a better sense of whether or not they needed needed vasopressors when you started high frequency percussive ventilation. Because if you ever try to do this retrospectively, it's very messy in terms of timing and charting. So things happen, but they don't always get charted at the exact time that they happen. So it can create confusion if you try to do this retrospectively. So kudos to them for doing a prospective study. But of course, no discussion of any study would be complete without a discussion of the weaknesses. So in this particular study, they had a small sample size, and this was related to, you know, several problems. One is that kids needing high frequency ventilation with bronchiolitis are rare. But the other thing is that the COVID pandemic really dramatically reduced the number of kids that were getting respiratory viruses. So they probably had they done this study 3 or 4 years ago, they probably would have been able to enroll quite a few more patients. There was no control group, so we really don't know, you know, if they had compared high frequency percussive ventilation to, say, prone positioning or jet ventilation or oscillator. Really don't know if high frequency percussive ventilation was any better or worse. There's no way to really know. And as I discussed earlier, they didn't protocolize high frequency percussive ventilation. I think that's really important because there's going to be a ton of variation in management between physicians and RTs. So it's really important that you try to protocolize these things if you can, so you have kind of a standard approach. And then, you know, as a lung mechanic kind of nerd, one of the things that it's a little bit disappointed in a prospective study is they didn't actually measure the lung mechanics before they went on high frequency percussive ventilation, which is most likely related to the fact that the kids weren't doing all that great, and then they just went ahead and transitioned them to percussive ventilation the same way that they would normally. But it would have been very valuable to get, you know, a plateau pressure, intrinsic PEEP, lung compliance, airway resistance. You know, if you could even get, you know, a dead space to tidal volume ratio or ventilation index or some other measure of illness severity that can help us compare different modes. So if we wanted to compare high frequency percussive ventilation to, say, jet ventilation, which we reported last year, one of the things that would be important to know would be the lung mechanics so that you can see if the patient population is actually super similar or not. Excuse me. And then again, very disappointing that they didn't report the pH values. This is probably due to the combination of arterial and capillary gases. They chose not to report that. And then I think, and this is important for us because, if you tell me that we're going to put somebody on high frequency ventilation because their CO2 65, the first question every RT is going to ask is, well, what's the pH, right? So if the pH is 7.35, we probably do nothing. If the pH is 7.12, right? So that's a lot. You might be much more inclined to do high frequency ventilation. So that's a really important piece that's kind of missing from this paper, unfortunately. And then they combine the arterial and capillary CO2, which probably reduces the precision of those measurements in terms of differences. And then I've beat this over the head with a hammer since we started, is they didn't measure the HFPV pressures with an external manometer, so that probably underestimates the true PIP. But it's not clear that this is necessarily harmful. It just creates a kind of a challenge when you interpret the papers, when you read a paper that says that the PIP was lower, but in fact, if you measured it at the airway with a manometer like you would for jet ventilation or even HFOV, it would actually potentially be quite high. And again, nearly all the subjects received paralytics, so they were all paralyzed, and the timing wasn't clear. So it's really hard to really tell for sure. Most likely the improvement in gas exchange was from HFPV, but we don't know that for certain. It could have been related to neuromuscular blockade, or it could have been related to some sort of synergistic effect between the two. So they decided that the patient wasn't doing well, so their standard practice is to put them on high-frequency percussive ventilation. So you paralyze the patient, you put them on a high-frequency percussive ventilation, they get better, and then there's no way to know what was the true driver, or if they both had some effect. And then the second point is something that we can't stress enough, and this comes up frequently in pediatrics and adults, is that strategies that improve gas exchange may not translate into improved outcomes. So this is critically important to remember, that just because something we do improves the gas exchange, so your blood gases get better, that doesn't necessarily mean your patient's going to do better. So if you kind of exceed the amount of energy that the lung can absorb without suffering injury, then the improvement in gas exchange is good. But if you go kind of above this threshold of whatever it is in terms of lung injury, then your gas exchange gets better, but then you significantly increase your patient's risk of death or other bad outcomes. And this is true. We don't have any randomized control trials for percussive ventilation, but this is pretty consistent what we see with HFOV. So we have several studies that either showed no benefit or harm. And the large study that showed harm in HFOV actually used a really aggressive mean airway pressure strategy. So the patients were on a mean airway pressure, I think, of 30. But what they consistently showed in both of the OSCAR and OSCILLATE trials was that the HFOV group had better gas exchange. So they had higher PF ratios and better CO2 clearance, but that didn't translate into improved outcomes. And the same thing that we see in APRV in kids is there was a trial done last year not last year, it's been 3 years, I think, 2018, of APRV, and they showed the same thing. So they actually showed the APRV group had better gas exchange and better improvements in gas exchange from baseline, but then the mortality risk was almost double after they controlled for some confounders. So that trial was actually stopped earlier. So APRV also can improve gas exchange, but that doesn't necessarily mean that the patients are going to do better. And then these things are also true for recruitment maneuvers, nitric oxide. The signal is pretty clear in adults that nitric has no effect on mortality. It may be associated with a small increase in risk of renal failure. The pediatric data is not as good, but also probably shows, at least so far, that there's no real benefit. And then really importantly is that you can actually improve gas exchange simply by having high tidal volumes. So that's what we saw in the ARDSNet study. So everyone focuses on the mortality curves, but I always thought that the two curves that show, and I should have put it on the slide here, but the two curves that show the PF ratios, where the high tidal volume rate group had higher PF ratios for the first week or so, and then the PF ratio starts to go down in the high tidal volume group, and then it goes up in the low tidal volume group until they cross, and then the patients die. So just because you've improved gas exchange doesn't necessarily mean that your patients are going to do better. And then in the discussion section, the authors really didn't discuss how complex the mode is, and they really didn't report all the settings management over time. So there wasn't a table, for example, that had the HFPV was set at this on day 1, and then this on day 2, and this on day 3, and that's a little bit kind of disappointing because it makes it harder for other centers to kind of replicate these results clinically or in another study if they want to. And in the editorial, this is Cheryl Dominic and the group from CHOP. They also have a ton of experience, and they published their very large case series last year in pediatric pulmonology with over 200 kids. And they suggest several things. One is to have a standardized approach to HFPV. So that would mean that different centers would have to agree on how to manage different settings and you know, how fast to set the percussive rate, what the conventional rate should be, how do you manage BIP and PEEP, how frequently do you make adjustments, and all of those things that are potential confounders in the results of this study, but also future studies. And then I briefly mentioned this earlier, but the circuit setup makes a big difference. So if you are putting the phasotron right at the airway, you're potentially having less pressure attenuation through the circuit than you would if you're using the turbo hub setup, which is what I believe Primary Children's uses. It wasn't in the paper, but I believe that's what they use. And that is actually pre-humidifier, which means that there's more pressure attenuation through the circuit, which hopefully is a little bit more lung protective than would if it's right up by the airway. And then what's really important is that we really need more centers to share their experience. And then we need lots of details on what they did. So it's one thing to say we put 35 patients on high frequency percussive ventilation and kind of this is what happened to them. But for me personally, in a prospective study, would have really liked to see lots and lots of details. So like really would have loved to see, you know, 6 hours after and 12 hours after what the VDR was set at, what the FiO2 was, what the gas exchange was, et cetera. And it would have been nice to kind of see that over time. Then it also would have been very helpful to see what the settings were and what the gas exchange was before they transitioned back from high frequency percussive ventilation back to conventional, because that's a big challenge that we have. We don't use the VDR anymore, but it's a big challenge that we have when we use jet ventilation, for example, or the oscillator is when is the time to go back to conventional ventilation, which is an area that is not just for high frequency percussive ventilation, but just for high frequency modes in general. We don't have a good sense of when's a good time to transition back. And then finally, what we really need for future studies is some sort of independent monitoring system. So you really want to figure out some way to put some sort of external pressure manometer into the circuit that can measure the pressures independently of the VDR. Because like I said early on, it actually reports the mean values and not the peaks, which is potentially misleading in terms of how much pressure is actually being delivered to the airway. And I will say our personal experience is that we have a VDR. We don't use it anymore, but we used to put the NM3 monitor and leave it in line. And I will say that the PIP read by the NICO monitor, the NM3 monitor, is quite a bit higher than what is set on the machine. And that may still be safe and that may still be okay, but I think we all need to be aware of kind of the limitations of the device. So future directions. So the things that we need to do in the future for not just for high frequency percussive ventilation, but lots of unusual interventions like kind of high frequency ventilation in general or APRV or things that aren't used a lot. So we really need multi-center studies. So we need, you know, not only CHOP to share their experience, but some of the smaller hospitals that don't use it as much. And we especially need the centers that didn't have a favorable experience to share their results. So if you have a VDR and you don't have very good success with it, it would be very interesting to the critical care community to know that, because right now, most of the places that have published have had favorable experiences and they're fans of the device and they use it a lot. But it would be nice to have a more balanced approach. And that's not just true of high frequency percussive ventilation. That's also true of jet ventilation or APRV or some other interventions that we do. And I think I would love to see a large randomized control trial that compares either staying on conventional ventilation or versus high frequency percussive ventilation, or jet ventilation versus high frequency percussive ventilation, or, you know, some combination of the oscillator thrown in there too. But I don't think that's ever going to happen. So you can see this is very rare. So this is a center that uses the machine quite a bit for bronchiolitis, and they were only able to enroll 35 subjects. We are pretty aggressive users of jet ventilation, and we did a similar study that we included kids with bronchiolitis, but also some other diseases. And we were also able to enroll 35 kids over the course of 4 or 5 years. So it's really hard to power a study that will really help us in decide what to use when the broncholytics are failing conventional mechanical ventilation. So the solution might be a large national registry, and potentially the ventilator companies could all kick in, and we could create a large registry for all kinds of high frequency ventilation. And then, like I already said, we need more centers to share their experiences, especially those that didn't have such a great experience. And then finally, I would love to see some physiologic studies using electric impedance tomography to assess lung volumes, because one of our concerns when we used it is that it might deliver more pressure than it says. So it'd be really interesting to see exactly what is happening and whether you actually, because the company is very insistent that you don't get over distension when you use the HFPV, but it would be very, very interesting and valuable if someone was to actually study that so that we could confirm that that is in fact true or untrue. And in conclusion, so high frequency percussive ventilation improved ventilation, so it decreased the CO2, but it didn't improve oxygenation as measured by the oxygen saturation index. And then thank you. So you can email me. That's my Duke email address with any complaints or questions or comments. I'll do my best to answer them. And you can follow me on Twitter. I only tweet about work, so you don't have to worry about too much craziness being true.
Okay, Andy, we've got a couple questions in the Q&A. You want me to read them for you and let you respond rather than you trying to read them?
Sure. I didn't click on the Q&A thing, so I didn't.
Okay, so the first one is from John Galligan, and he says, this looks like APRV with an oscillation overlaid it. Could you do the same thing with a conventional ventilator and some kind of percussive nebulization as an intermittent treatment?
So you could. And there's places that actually treat their bronchiolitis patients kind of in a similar manner, where they don't necessarily use a 1-to-1 IDE ratio on the regular ventilator, but they will do intermittent IPV or metaneb or whatever you have at your center, kind of intermittent treatments to clear secretions. I think if you're managing a broncholytic patient on a conventional ventilator, you have to be very careful about air trapping. So you're probably not going to be able to do a 1-to-1 IDE ratio without significant air trapping. And I think APRV is probably not a great choice in this patient population because of the high air resistance, and you're going to end up with difficulty managing auto PEEP and secretions and things like that. So there is confusion out there, and Rich may be able to answer this better than me, but there's confusion out there where people will say HFPV is like APRV with a wiggle, but I don't think of it that way. I think of it more as a conventional mechanical ventilation with the high frequency percussive breaths overlaid on it versus similar to APRV with the P high and P low.
So I'll throw in what I think it's not the same as overlaying it, because the best way for me to explain it and to understand it is that, pretend like you have a super syringe in your hand that's a liter in volume, and you're going to push 500 of it into the patient. So you grab the plunger and you push forward and it delivers it at 40 liters a minute. When you use HFPV, you're still going to deliver that same volume, but let's say you deliver the first time you push the piston forward, you push in 50 milliliters and then you stop for a second. And then you push in 40 milliliters and you stop for a second, because the phasotron is a sliding venturi, and as the pressure in the lung goes up, the volume of the next percussive breath goes down because entrainment falls. So it's kind of an interesting way of doing it. And of course, when you pause, even for these very short periods of time, when you pause, there is some gas, the lung recoils and some of the gas comes back out, which is why the higher the frequency of the percussions, the better the PO2, but the worse the CO2, and the slower the frequency at 150 or 200, the better the CO2 elimination. And Andy and I have talked about this before, that again, the EIT is a perfect idea because it is so hard to measure what's happening with the device, depending on how you monitor it and where you monitor it, that it would be very helpful to know, because John Marini's always showing and I'll try to do this quickly. He always shows, if you hold a coffee cup in your hand and you're standing up and you drop it, when it hits the floor, it will break. But if you hold that coffee cup at that same height and then drop it down a stair 6 inches and then drop it down another stair 6 inches, it'll make it to the ground. And it all has to do with energy dissipation. So maybe there's something to the whole way that thing delivers gas that does something positive in the distribution of ventilation. And there, again, the inventor had lots of thoughts about that, just no proof. And that's the problem we still have in 2022. Okay, the next question is basically summarized from Daniel Lozano. Do we know how many sites use this device? Is it a lot? Is it very few? Is it infinitesimal?
Is it infinitesimal? That's not a word you hear every day. I will say I don't know. I think that from talking to people, there are some places that use it very vigorously and they are strong believers. Then there are other places that use it a little bit in kind of select patient populations. Then there are quite a few places that don't use it at all. So I can't give you any numbers, but I would say that it's probably, generally used quite a bit in burn centers. And then in PICUs, it's going to be hit and miss, but I don't have any hard data on that.
Okay. There's a question about, because of it's a pneumatic ventilator, do you have problems with the settings drifting from the last time you looked, like we used to in the old days? That was the reason we always did Q2 ventilator checks, because if you didn't check it, it might actually be a different pressure and a different I time.
Yeah, so that is a great question. So I think one of the reasons that lots of centers, that if they're on high frequency percussive ventilation, the RT either stays in the room with the patient all the time, or they check the ventilator, Q1 or Q2 versus Q4 for other ventilators. And that's exactly why, right? So a little bit of change in, say the cuff leak decreased or the patient got turned or something like that, that could change how much pressure is being delivered or what the I time is or what the expiratory time is. So there's a lot of time spent fine tuning the settings, which is one of the reasons that, I wouldn't say that's one of the reasons we don't use it. We don't use it because we had some barotrauma when we used it, but it was a very challenging thing because it wasn't like what we're used to, right? Which is popping in and changing the settings for a few minutes and watching the patient. This was, you're looking at sometimes 20 minutes or 30 minutes of time fiddling with all the dials to try to get things back to where they were, which is a big challenge, especially now and with everybody being short-staffed and burnout rates being really high.
So one of the last questions is, what kind of ages are we talking about? And I guess you can address this particular study and then maybe in general.
Yeah, so this particular study was in babies. They were a median of 4 months old, which is a pretty typical age for broncholytics that require mechanical ventilation. And there are some centers that use it in neonates. I haven't seen much in the way of published data in neonates, other than there's a few case series. And then the CHOP case series is probably the biggest and kind of the best in pediatrics that I've seen. And that was over 200 patients, and they use it in bronchiolitis and burns and secretion clearance. And they use it for a variety of other reasons, ARDS. But it can be used all the way up to adults. So there's, I think Felix, I'm not going to try to say his last name, but Felix up in New York, they use it all the time for ARDS and kind of lung rescue. And I believe Kenny Miller's center used it quite a bit in Pennsylvania. So I think it's something that you can use at any age range, but given the published data, it's very hard to figure out exactly when and why and how we should use the machine, which is one of the reasons why this is such a compelling paper, but also one of the reasons I was personally a little bit disappointed that they didn't report more data to help guide us. So like if we wanted to start using the VDR again, like this paper doesn't really give us the detailed data that we would really need, especially on how to make adjustments and things like that.
So Andy, I want to, interject, which I guess you can do as the moderator, but you and I have talked about this at times. There are a couple things that are concerning. One is, it's surprising, and I even worked with one of the Army surgeons who did some of the original work on burns in the VDR, with the idea that the percussive action helped move secretions cephalate and get them suctioned out. There are a couple things that make that counterintuitive. One is, and you showed the phasotron, the gas in the phasotron, it's a sliding venturi. The gas going in the top of it is completely anhydrous. It has no humidity. It doesn't pass through a humidifier. The gas that gets entrained can have humidity in it. So no matter what you do, the gas you're going to deliver is going to be less than 100% relative humidity. It has to be. And you would think, well, if I have thick secretions or burns with airway secretions, that would be a negative. The other thing that might be a negative is we know from the data in both mechanical ventilation and mechanical insufflation exsufflation is that if you want to make secretions come upward, you put the air in slow and then bring it out fast. And this does exactly the opposite. The percussive breaths are under pressure, and then the spring tension pulls the venturi back, and there's a passive recoil of the chest. Now, having said that, I think anybody who's used it has seen you put patients on it, and all of a sudden the secretions start coming out. But I think there is a problem with humidity with the VDR, and I see people put two heated humidifiers in line, and I think if you deliver 100% relative humidity at 37 degrees to the inlet of the venturi, two humidifiers doesn't allow you to give 200%, and that needs to be addressed at some point. The other thing is what you mentioned, which is the airway pressure. So what is the airway pressure? If I read the airway pressure on my ventilator in the ICU that costs $50,000 and has a solid state NIST traceable pressure transducer that's accurate to 1/10 of a centimeter of water pressure, and then I switch to the VDR and I either look at the manometer on top, that's just a standard manometer, or I look at the waveform screen, how do I compare what was happening before with what's happening now? And if you ever take a VDR apart, between the connector for the airway pressure and the manometer that's in the machine is a device that's called a snubber, and it basically is a tube within a tube that's surrounded by a little ring, and you move it, and what you're doing is decreasing the orifice size going into the manometer. And those of you who are old enough like me will remember that before we had mean airway pressure monitors and neonates, if we wanted to measure the mean airway pressure, we'd hook up a manometer and then crimp the Tygon tubing with the hemostat so that you neither saw the peak nor the trough, but you kind of saw the average pressure. It wasn't really accurate. So there's a lot of, we don't understand what the airway pressure is. And these are, unfortunately, when I started using the VDR in 1984, and we used it quite a bit, the fact that we still haven't answered those questions is a real concern for me.
Yeah, I agree. I think I should have talked a little bit more about the humidification issue, which is a problem in all patient populations, but particularly concerning in kids with bronchiolitis with thick secretions. So despite the fact that there's a lot of anecdotal evidence saying that putting a patient on or using IPV or HFPV results in a ton of secretion clearance, when we reviewed all the literature last year or the year before, we couldn't really find any papers that objectively measured that. So there's a case report here, a case report here. So it's something that's very difficult to study in terms of objective secretion clearance, but also something that it could actually worsen secretions if it dries the gas out, which is what we experienced when we used it periodically on our ECMO patients.
Yeah, and I think I'm not trying to oversell this, but maybe it is that the percussive action of to fill the lung, and then all of a sudden the sudden exhalation really forces the secretions forward. Again, that's a postulate. I don't know that to be true. Okay, so we're getting a little late here. I do have to apologize because before we got on, I was having all kinds of issues, so I skipped our disclosure statements. And Andy is again the section editor for respiratory care, so a part-time paid by Daedalus, and has received honorarium for Sachs Communications, and I'm the editor-in-chief and get paid by Daedalus, and have disclosures, none of which are related to this. Any of the brand names that we talked about here are mentioned as examples of technology, but we had to talk about the VDR because that's what this paper is about. The brand names, when we talk about them, are not meant to be an endorsement of a specific product, but merely to illustrate a point of emphasis and to provide information and education regarding the availability. Again, Andy, this is really nice. Thank you for doing it. I appreciate you being here today.
Thanks for inviting me.
Please join us for our next webcast on August the 10th, when Eric Kreiner will present Recognizing Work Shifting and Asynchrony During Breath Delivery. And on August 26th, the next JournalCast will be a presentation by Jeffrey Haynes about the use of filters in the pulmonary function laboratory in the era of COVID-19. Thank you again for joining us, and have a great day.
Great. Thank you, Rich. One more thing. If you are a group participant, please have your group leader submit your information to the group attendance tab to be provided with follow-up instructions on how to submit for credit. If you do have any questions, please email crce@aarc.org. This does conclude today's presentation. Once the course is marked concluded, the system will automatically submit credit for you. You can check the status in your credit submission tab. And we all hope you have a great rest of your day.